Okay. Good morning, everyone. Today's topic is ectopic pregnancy. Myself, Dr. Tejashree Chandawar from OBGY department as a senior resident. So here I will explain about what is the ectopic pregnancy, how it happens, causes, complications, then treatment. So what is the definition? Any pregnancy where fertilized ovum gets implanted and developed in a site other than normal uterine cavity. It represents a serious hazard to a woman's health and reproductive potential, requiring prompt recognition and early aggressive intervention. So, in this diagram, I am showing this is fetus. This is fallopian tube where it is shown. So, fetus is in fallopian tube and this is uterus. So, fetus is outside the uterus where it is implanted outside the uterine cavity. It is called as ectopic pregnancy. So, what are the implantation sites where fetus can be stayed or where fetus can be implanted? So, it is divided into extrauterine and uterine. In extrauterine, tubal percentage is 95 to 96%. In tubal, four mid divisions will be there, the parts will be there, and most important part is ampulla. Ampulla will be 70%, isthmus will be 25%, and then interstitial, that is 18%, and infundibulum, that is 2%. So first will be 70%. In that, tubal is the most important, and so many cases will be in tubal ectopic pregnancy. After that, ovarian, and after that, abdominal. In abdominal, it will be primary and secondary. In secondary, again it is followed by divided by intraperitoneal and extraperitoneal. In extraperitoneal, broad ligament will be the rarest factor. So this is like in extrauterine. In uterine, first there will be cervical, followed by angular, third will be C-section cesarean, and fourth will be corneal. So these are the implantation site where fetus can get implanted, and the most common here is tubal pregnancy, followed by ovarian, followed by abdominal. So this diagrams I am showing in this diagram, here I am showing this is interstitial part near the corneal fallopian tube. This is femora. So near the corneal portion it will be interstitial, followed by isthmus, ampullary, where ampullary is the most important part where ectopic, most common part where ectopic can be implanted, where fetus can be implanted, and this is fallopian tube. This is uterus, cervix, this is ovary, abdominal, ovarium. Okay. Now incidence and mortality. It is increased in most common in PID patient, that is pelvic inflammatory diseases. Then IUCD, then tubal surgeries, followed by assisted reproductive technique. The rate in India is 5.6 per 10,000 deliveries. Then it is common in the late marriages and late childbearing, greater than 2%. ART, that is artificial reproductive technique, it is more in artificial, greater than 5%. It is present in the recurrence rate will be 15% after first ectopic pregnancy, 25% after second two ectopic pregnancy. Okay. So what is etiology? Any factor that cause delayed transport of fertilized ovum through the tube. Fallopian tube favors implantation in the tubal mucosa itself, thus giving rise to tubal ectopic pregnancy. These factors may be congenital or acquired. etiology, that is, if congenital, it is more common in what tubal hypoplasia. There will be a tortuosity, congenital diverticuli, accessory ostia, partial stenosis will be there, elongation will be there, intramural polyp will be there, and entrap the ovum on its way. Then in acquired pelvic inflammatory disease, in pelvic inflammatory disease is more common, 6 to 10 times more common than other things. And the chlamydia trachomatis is the most common than any other organism. Then in contraceptive failure, copper T will be a 4%. In progesterone, if we are giving in progesterone, then 17% will be failure chances and ectopic pregnancy will be 17% more. Mini pills, that is progesterone only pill, that is 4 to 10%, and Norplant, that is 30%. Then failure of sterilization, recanalization of the fallopian tube. Again, if we canalize the fallopian tube for the pregnancy, for future pregnancy, if any patient wants again for pregnancy, they has to canalize the fallopian tube. But it is more common ectopic pregnancy will be happen in recanalization of the fallopian tube. But it depends on method of sterilization, site of the occlusion, and tubal length. Then in tubal reconstructive surgery, 4 to 5 times it is more common. Assisted reproductive technique, ovulation induction, IVF, then risk of heterotropic pregnancy 1%. Previous ectopic pregnancy, previously I told you, in first previous 7 to 15% chances of repeat ectopic, in 2 ectopics 20% chances of repeat ectopic. Other risk factor, age 35 to 45 years, previous induced abortion, previous pelvic surgery, cigarette smoking, diethylyldestrol exposure in utero, infertility, salpingitis ischemica nodosa, genital tuberculosis, fundal fibroid and adenomyosis of tube, and transperitoneal migration of the ovum. What is the hypothesis for that? Theory of reflux menstrual fluid through the fertilized ovum in the tube. Factors facilitating nitation of the ovum in the tube. Premature degeneration of the zona pellucida, increased decidual reaction, and tubal endometriosis. These are the factors facilitating nitation of the ovum in the tube. Remember, premature degeneration of zona pellucida, increased decidual reaction, and tubal endometriosis. So what is the anatomy? Here I will explain how it happens. Changes, implantation, intercolumnar or between mucosal fluids. Decidual change will be minimal. In normal pregnancy, decidual change will be more. Here, muscle hyperplasia and hypertrophy minimum. There will be more. In normal pregnancy, muscle hyperplasia will be more and hypertrophy will be more. Intramuscular implantation, pseudocapsule formation, trophoblast invasion, erosion of the blood vessels. The pregnancy is unable to survive owing to its poor blood supply, thus resulting in tubal abortion, reabsorption, and tubal rupture. In stomach, the tubal abortion will occur in 6 to 8 weeks, in ampullary 8 to 12 weeks, and interstitial 4 months. These are the parts of the tubes. Whatever I am explaining, that is in stomach, ampullary, and interstitial, and fundal. These are the part of the tubes. Abortion is common in ampullary pregnancy, whereas rupture is common in ischemic pregnancy. So the diagram is showing how it is showing a ruptured ectopic. It looks like this. The bloods, it will be ruptured. So blood will be there, active blood will be there. Now, how we approach the patient? What are the diagnoses? How can we approach? What should we ask the patient? Diagnosis can be done by history, digital examination, and judicious use of investigation. History of past PID. tubal surgery, current contraceptive measures. Previously, I had explained about IUCD, copper T, progesterone. That contraceptive should be asked. Wide spectrum of clinical presentation from asymptomatic patient to other with acute abdomen and in shock. Acute ectopic pregnancy. Classic triad is present in 50% of patients with ruptured ectopic, that is pain. Most constant feature in 95% patient, variable in severity and nature. Followed by amenorrhea, that is 60 to 80% of the patient. There may be delayed period or slight spotting at the time of expected menses. Vaginal bleeding, scanty dark brown. Feeling of nausea, vomiting, fainting attack, syncope attack due to reflex vasomotor disturbance. Abdominal pain most common. Feature shoulder tip pain due to diaphragmatic irritation. Okay. On examination, patient is restless in agony, looks blanched, pale, sweating with cold, clammy skin, feature of shock, tachycardia and hypotension will be there. Per abdomen, abdomen become tense, tender, mostly in the lower abdomen, shifting dullness will be there, rigidity may be present. Per speculum, minimal bleeding may be present. And per vagina, uterus may be bulky, deviated to opposite side. Fornix is tender. Excitation, pain on movement of the cervix. POD may be full. That is, pouch of Douglas may be full. It will be like fullness of the pouch. Something will be there or either hematoma or blood. Uterus flows as if in water. Now, unruptured ectopic. So, there will be high degree of suspicion and ectopic conscious clinician can diagnose. Diagnosed accidentally in laparoscopy or laparotomy. Clinical features: delayed period, spotting with discomfort in the lower abdomen. Per abdomen, tenderness in the lower abdomen. Per vagina should be done gently. Uterus is normal size, firm. Small tender mass may be filled in the fornix. In ruptured acute ectopic, uterus was bulky. Okay. Investigations. How can we diagnose? By transvaginal sonography, radioimmunoassay of beta HCG and laparoscopically. Then chronic ectopic pregnancy. Symptoms: it can be diagnosed by high clinical suspicious. Patient has previous attack of acute pain from which she has recovered. She may have amenorrhea, vaginal bleeding, with dull pain in abdomen, with bladder and bowel complaints like dysuria, frequency of urine or retention of the urine, and rectal tenesmus. On examination, patient look ill, varying degree of the pallor, slightly raised temperature, feature of shocks are absent. Feature of shock are absent. Per abdomen, tenderness and muscle guard on the lower abdomen. A mass may be filled, irregular and tender. Vaginal mucosa pale. Per vagina, vaginal mucosa will be pale. Uterus may be normal in size or bulky. Ill-defined boggy tender mass may be filled in one of the fornix. Cullen signs, that is dark bluish discoloration around umbilicus, suggests intraperitoneal hemorrhage. Now diagnosis. Acute ectopic, classic history of fainting, attack and collapse with hemorrhagic points towards acute ectopic. Blood examination, AV1, RH grouping, etc. In chronic ectopic, difficult to diagnose, confusing absence of amenorrhea, absence of vaginal bleeding, bleeding followed by pain, and normal general condition. Presence of bilateral mass, previous history of pubectomy. Patient with acute ectopic can be diagnosed clinically. Blood should be drawn for hemoglobin, CBC, blood grouping and cross-matching. Serology and coagulation profile. Should be catheterized to know urine output. Bedside test. Urine pregnancy test. Positive in 95% of the cases. ELISA, that is sensitive to 10 to 15 milliIU by ml of beta HCG and can be detected in 24th day after LMP. Remember that it is detected on 24th day after LMP. Cool synthesis 70 to 90% can be done with 16 to 18 G lumbar puncture needle through posterior fornix into pouch of Douglas. Positive tap is 0.5 ml of non-clotting blood. That was blood investigation. Now we will further proceed to ultrasonography. It is divided into transvaginal, transabdominal. Transvaginal, it is more sensitive. It detects intrauterine gestational sac at 4 to 5 weeks and serum beta HCG level as low as 1500 international unit per liter. Diagnostic feature are absence of intrauterine pregnancy with positive pregnancy test, fluid in the pouch of Douglas, adnexal mass clearly separated from the ovary. Rarely, cardiac motion may be seen in unruptured. Color Doppler sonography. That was transvaginal, now the color Doppler. It improves the accuracy. Identify the placental shape, that is ring of fire pattern. The diagram is showing as the ring of fire pattern, okay, and blood flow outside the uterine cavity. Now we will further proceed transabdominal sonography. Can identify the gestational sac at 5 to 6 weeks. Transvaginal was diagnosed, can be identified 4 to 5 weeks. So transvaginal is more sensitive and can be diagnosed early. Serum beta HCG at which intrauterine gestational sac is seen by transabdominal is 1800 international unit. That was 1500. This is 1800. So this diagram is showing that spots are there, that is a ring sign, a hyperechoic ring around an extrauterine gestational sac. Now beta HCG. Single beta HCG little value. Serial beta is required when result of initial USG is confusing. When HCG level is less than 2000 international unit, doubling time help to predict viable versus non-viable. Rise of beta HCG less than 66% in 48 hours indicate ectopic pregnancy or non-viable intrauterine pregnancy. In normal pregnancy, what happens? After 48 hours, the beta HCG will be double the previous HCG, and in ectopic pregnancy, it will decrease. So, we can actually diagnose by beta HCG level also. Biochemical pregnancy is applied to those women who have 2 beta HCG values greater than 10 international units. Then serum progesterone level greater than 25 nanogram per ml is suggestive of normal intrauterine pregnancy. Less than 15 is suggestive of ectopic pregnancy, remember. And level less than 5 indicates non-viable pregnancy, irrespective of its location. Okay. Diagnostic laparoscopy, it is a gold standard. Can be done only when patient is hemodynamically stable. It confirms the diagnosis and removal of ectopic mass can be done at the same time. So it is a gold standard. After that, dilatation and curettage is recommended in suspected cases of incomplete abortion versus ectopic pregnancy. Identification of decidua without chorionic villi is suggestive of extrauterine pregnancy. So with chorionic villi will suggest of normal pregnancy, and without chorionic villi will suggest of extrauterine. Aries-Stella endometrial reaction is suggestive but not diagnostic of ectopic pregnancy. Other novel tests, rather than this, placenta protein, decrease in ectopic pregnancy, pregnancy associated plasma protein A and squat protein 1 has low value in ectopic pregnancy. Then CA125 maternal serum creatine kinase maternal serum AFP elevated in ectopic and VEGF. Now, what are the differential diagnoses of acute ectopic? Rupture corpus luteal of pregnancy, it will definitely show like same picture of the ectopic pregnancy. Pain, bleeding, followed by hematoma, followed by tenderness in abdomen. rupture of chocolate cyst, twisted ovarian cyst, torsion, degeneration of pedunculated fibroid, incomplete abortion, acute appendicitis, perforated peptic ulcer, renal colic, and splenic rupture. Diagnosis of chronic ectopic. Pelvic abscesses, pyosalpinx, that is fluid in the pus in the tube, that is salpinx. Subserous uterine fibroid, salpingitis. Okay, then retrovated gravid uterus and appendicular lump. Management. Here management is divided into three parts: expectant management, medical management, and surgical management. Medical management is divided further into two parts: local, that is usual laparoscopic salpingocentesis, and systemic, that is methotrexate. So other than methotrexate, what we can do with potassium chloride, prostaglandin, hyperosmolar glucose, actinomycin D, and mifepristone. This is antiprogesterone. Then surgical management. In surgical management, it is divided into radical and conservative. Radical is salpingectomy, that is tube will be removed. Conservative salpingostomy, we will cut the tube and then we will restitch that tube. Salpingotomy, and then segmental resection. Part of the tube, actually part of the tube we will remove and then we will stitch both the tube close. Segmental resection. Okay, milking or fimbria expression. So, management of ectopic principle, resuscitation and laparotomy, laparoscopy. Guys, please, it is important, whatever and whenever the patient comes, a patient is in shock, we have to settle the patient. That is for anti-shock treatment we have to give, that means resuscitation, and after that further proceed fast either with laparotomy or laparoscopy or medical management. Okay, so and in anti-shock treatment, what we have to do? First, we have to, at the most important, IV line made patient, crystalloid it started, that means salines, fluids, everything. Blood sample for hemoglobin, blood grouping, and cross matching. BTCT, bleeding time and clotting time. Foley's catheterization should be done. Colloids for volume replacement. Colloids, that means blood. Laparotomy, followed by all this we had done, and after that we have to go very fast. That's why in laparotomy principle is quick in, quick out. That means rapid exploration of abdominal cavity is done. Salpingectomy is the definitive surgery. The tube will be sent for histopathologist report, blood transfusion to be given, and auto transfusion only when donated blood not available. Remember. Management of ectopic, laparoscopy, preferred method if hemodynamically stable. If patient is stable, then we can do laparoscopy. That was laparotomy, that means open surgery. Laparoscopy, by laparoscope, tubal patency, no significant difference. Followed by similar number of uterine pregnancy, short operative time. Okay, so what are the advantage of laparoscopy? Tubal patency will be there, followed by similar number of uterine pregnancy, short operative time. Salpingostomy, less than 2 cm size, 10 to 15 mm incision will be given. Less than 2 cm size, if ectopic will be there, we can do salpingostomy. Management of unruptured ectopic. There are options: surgical, surgically administered, and medical treatment, and expectant management. So, but for expectant management, there will be a criteria. If the patient fits in that criteria, then we can do a medical treatment. Okay. So, first criteria is tubal ectopic pregnancy only and only. No other ectopic pregnancy. That means ovarian, abdominal. That means patient should be hemodynamically stable. No rupture or bleeding. Adnenaxal mass of less than 3.5 cm without heartbeat. That means cardiac activity should be absent. Initial beta HCG should be less than 1000 international unit and falling in the titer. Single best. Success rate up to 60%. Protocol: hospitalization with the strict monitoring of clinical symptoms. Daily HB estimation, that is hemoglobin. Serum beta HCG monitoring 3 to 4 days until it is less than 10 international units. Transvaginal sonography should be done twice a week. Expectant management: spontaneous resolution in 72%, while 20% will need laparoscopic salpingostomy. In spontaneous resolution, it may take 4 to 6 days, mean 20 days for the serum to return to normal pregnant level. The percentage fall in serum by day 7 is a better indicator than the percentage fall by day 2. Warning: tubal pregnancy have been known to be ruptured even when beta serum HCG level are low. Remember. Medical management: surgery is the mainstay of treatment worldwide. Medical management may be tried in selected cases that I have already described. What are the selected cases? Okay. Now, candidates for methotrexate: unruptured sac less than 3.5 cm without cardiac activity, serum HCG less than 10,000 international urine, persistent ectopic after conservative surgery. So, physician checklist: CBC, LFT, RFT, serum beta HCG, transvaginal USG within 48 hours, obtain informed consent, anti-D if the patient is Rh negative. So, here is the table: medical management, single dose of methotrexate 50 mg per meter square. According to that dose, we have to give intramuscular. Beta HCG level should be followed at day 4 and the 7. If difference is greater than, repeat weekly till less than 5 international. If difference is less than 15 between day 4 and 7, repeat dose and begin day 1. If fetal cardiac positive at day 7, repeat day 1. Medical management: if beta HCG not falling or fetal cardiac positive after 3 doses. Okay. 2 doses on day 0 or 4 followed up same as 1 dose resume. Variable dose. Other than that, methotrexate can be given by 1 gram per kg intramuscular on day 1st, 3rd, 5th, 7th, and followed by leucovorin, that is folinic acid, 0.1 mg per kg IM on day 2, 4, 6, 8. So alternate. First day methotrexate, second day leucovorin, third day metho, fourth day leucovorin, like that. In this, measure beta HCG level at day 1, 3, 5, 7, alternate day, every 48 hours. Continue alternate day regimen until beta HCG level decrease greater than 15% in 48 hours or 4 doses of methotrexate given. Then weekly betas until less than 5 international unit. Advantages are, for medical management, advantages are minimal hospitalization, usually outdoor treatment, quick recovery, 90% success if cases are properly selected. That means that criteria should fit the patient. Disadvantage: side effects like gastritis, skin problem. Monitoring is essential. Total blood count, LFT and serum HCG once weekly till it becomes negative. That means less than 5. Surgical management of ectopic conservative surgery can be done laparoscopically or microsurgical laparotomy. Indication: patient desires for future fertility, contralateral tube is damaged or surgically removed previously. Choice of technique depends on localization and size of gestational sac, condition of tubes and accessibility. Various conservative surgery. Linear salpingostomy indicated in unruptured ectopic less than 2 cm size in ampullary region. Linear incision given an anti-mesenteric border over the site and product removed by finger, scalpel handle or gentle suction and irrigation. Incision line kept open. Heals by secondary intention, that is salpingostomy. Okay. Linear salpingotomy, incision lies is closed in 2 layers with 7-0 interrupted vacuole suture. Segmental resection and anastomosis. What is that? Indicated in unruptured stomach. Remember, salpingostomy, it is done in the ampullary region, and segmental resection it is Dr. Tejashri. Segmental resection it is done in ischemic pregnancy. Milking or fimbrial expression. This is ideal in distal ampullary or infundibular pregnancy. It has got increased risk of persistent ectopic pregnancy. So nowadays we are not doing this fimbrial expression. Advantage of laparoscopy, it helps in diagnosis, evaluation and treatment. Diagnose other cause of infertility. Decrease hospitalization, operation time, recovery period and analgesic requirement. Follow-up after conservative surgery. With weekly serum beta HCG titer till it is negative. If titer increases, methotrexate can be given. So what is persistent ectopic pregnancy? This is a complication of salpingostomy when residual trophoblast continues to survive because of incomplete evacuation of ectopic pregnancy. Diagnosis is made because of raised postoperative beta HCG. If untreated, can cause life-threatening hemorrhage. Risk factor: early ectopic pregnancy, less than 6 weeks, amenorrhea, smaller size less than 2 cm, incomplete removal, preoperative high serum beta HCG greater than 3000, and postoperative day 1 titer is less than 50% of preoperative layer is predictor of persistent ectopic pregnancy. Implantation medial to salpingostomy site surgery. Total or partial medical, selected asymptomatic patient, methotrexate plus leucovorin. Thank you guys.